If youth experience trauma, will they have PTSD, thus making them prone to exhibiting negative behavioral problems or patterns? Is increasing access to mental health care for youth/students with PTSD or trauma a means of addressing the problem? According to U.S. National Library of Medicine and National Institute of Health, 40% of high school students have experienced some form of domestic or community violence, and between 3 and 6% have PTSD. High rates of trauma exposure and evidence of PTSD among child populations suggest that mental health practitioners worldwide need to be able to recognize those post-traumatic reactions in children that require intervention and offer effective treatments. This is particularly critical given the substantial challenges that post-traumatic stress poses to the healthy physical, cognitive, and emotional development of children and adolescents. Database searches were conducted and several research articles identified not only prevalence of PTSD in youth, but also discovered that interventions such as CBIT are effective when administered to youth. Initially, a general search was conducted using Google to identify where research was conducted. Subsequently, other databases were used in an effort to condense findings. Databases such as PsycInfo, EBSCO, ERIC, and Google Scholar were also used. It is very important to note that the research was conducted in accordance to the NASW. For example, we clinicians must consider one's race, ethnicity, cultural realities, dignity, and self-worth, ensuring a high standard of professional practice behaviors. Confidentiality involving minors, competency are all values which must be held by clinicians. 4 modes of research were conducted, all using CBT as an intervention for youth with PTSD. In all 4 cases, the goal of the research conducted was that of reducing students' symptoms in PTSD and depression. Databases such as PsycInfo and Google Scholar generated specific articles of research conducted which were used to determine what the best course of interventions are best to use when confronting the issues of PTSD and youth. The percentage of students who participated in CBT interventions were positively impacted. Childhood PTSD lends itself to both over and under diagnosis, especially when assessments are not thoroughly or expertly conducted. There are a number of assessment instruments available to aid the diagnosis of PTSD in children. While PTSD in older adolescents is similar to adult PTSD, there are 2 major limitations of the PTSD diagnosis criteria when assessing post-traumatic pathology in young children. Firstly, 8 of the 18 PTSD criteria require a verbal description of internal states and experiences, a task beyond the cognitive and expressive language skills of young children. The clinician must therefore attempt to infer from behavioral observations whether the child's thoughts and feelings are consonant with PTSD symptoms. So, today, I come to you, my colleagues, knowing that what I am proposing is momentous. I believe that we can begin to raise the funds necessary to create more research, training, and implementation of CBIT in schools, in homes, and in clinical settings that will engage children beginning at the age of 5 years old. I am proposing that we solicit state funding and legislation that will help us forge new paths of intervention to those who are the voiceless. These are children who experience trauma but are not able to articulate their pain. So next month, we will begin seeing 5 children, 5 to 8 years old, who recently were exposed to gun violence at their elementary school. Our goal is to provide CBIT and monitor them for a duration of 10 years. We will work in conjunction with school staff, counselors, and parents to ensure continuity while we clinicians apply interventions which will produce coping skills and healthy behavioral patterns. Thank you.